Dr. Christina Gaardner. She's a consultant general and trauma surgeon and head of traumatology, Oslo University Hospital, U-Level, Norway. She has had several deployments as a reservist with the Norwegian Armed Forces. She's the founder of the OUHU Dedicated Trauma Service in 2005, and she later initiated the Norwegian National Trauma Advisory Unit. She serves as the trauma chair of the board of the Norwegian Surgical Society. She's the immediate past president of the International Association for Trauma, Surgery and Intensive Care. And she also serves as the chair of the Visceral Trauma Surgery in the European Society for Trauma and Emergency Surgery. So let us welcome Dr. Tina Gaardner with her speech on preparing for a terrorist attack. Dr. Tina.
First of all, I want to say thank you to the organizers for the invitation. I also have no disclosures apart from the fact that I agree with all the previous speakers on everything they said, and I don't think there's any disagreement in the simple messages we're trying to get through to everyone who is preparing for a mass casualty incident. And I think that it's naive to think that it's not going to happen anywhere for everyone. So I think we have to, because it's sticking our heads in the sand if we don't think this can happen to us. And how do we prepare for that? I will try to keep simple messages as well. And when the disaster is a fact, the system has to work. And I have put that as my title instead of how to prepare for it, because I think that this is summing up the whole talk. It was already mentioned by several of the previous speakers. There we go. So and you've seen this picture already, when this has happened, it's too late for training. So preparing is training. Training is too late when the disaster is a fact. So what we have, and I think this also is a summary of the experience we had, we didn't learn much new from when our situation or our incident happened 10 years ago. We sort of knew beforehand what was going to happen, but we had the fortune of then getting the confirmation that these are the main aspects. So what I want to say is, if you look at those four triangles, first of all, it has to be built on your everyday system. And there's no excuse for not developing a system. I think the introductory video at the beginning of this seminar said something about how to develop systems. I think everywhere, despite limited resources, it is possible to improve the systems, to define systems. And then the individual skills of the individual healthcare worker, everyone has a responsibility for being the person who has had ATLS or similar, who has been trained, so that the hospital or the system has teams that can work together and know what they're doing when they are faced with traumatic patients. And then you can train logistics. You can train parts of the logistics. You can train evacuation of your ED. You can do that every week. You can train evacuation of your ICU. You can train calling in of personnel. You can train gathering your crisis management group, etc., etc. Everything, all those small parts of the system you can train. And then there is on top of that, and this was very much said by Avi as well, is the clinical leadership. Your best and most influential clinicians have to be on top of this, and they have to be able to improvise, because the next time is not going to be the same as the experience you have with the previous time. So then we're back to, do you know your MCI plan? Most hospitals in the world, they have an MCI plan. So asking the personnel in the hospital, and we do that regularly, asking whether people actually have read the MCI plan. Do they know what their role is? Do they know where they're going to go when they come to hospital, when they're called in? How do we make sure that they do? Because we have to make sure that they do as leaders in the hospitals. And more than anything else, I think maybe, is the MCI plan actually relevant? Is it a plan developed by clinicians, or is it a plan developed by administrators? Because then it's not going to be relevant in the situation. So I think there has to be clinician involvement in the planning, not only at the date when it actually happens. This is the most recent issue from British Journal of Anesthesia, and it's actually, I recommend to you to read it. It's a special issue on disaster management and planning and training. And what it does say, it's summing up all the different, in some of the reviews, summing up the experience we have so far. And as has been already mentioned, there is a lot of experience over the last couple of decades on this. And I think one of the interesting titles in that is the embracing of uncertainty. It was mentioned by Paul in the beginning. Limited. You have to assume that there is limited and not enough information from the beginning. You have to make your plan so that it actually includes a knowledge that you don't know enough of what you're going to have. You have to assume that it's going to be more. You have to assume the worst case. And then the generic elements are quite simple, based on your system. And you have to build your system. If you don't have a system already, you have to put that at the bottom. I have to build my system so that I am able to step up the day when it's going to be overwhelmed. Leadership and governance, competence, training, and simulation. And it's an ongoing, never-ending story or task to make sure that everyone gets the training, that the system gets the training, that the leadership and management gets training. Communication is important, obviously. We talked about triage, we talked about surge capacity, supplies and safety, obviously, as well, but we'll come back to that towards the end. I think the main problem is in the management of personnel and personal competence. We have to build on the existing system. I can't emphasize that enough. And minimal acceptable care has been mentioned by several of the speakers. Minimal acceptable care as in damage control for the institution, not necessarily because the patient is unstable, but because the institution requires you to do as little as possible, or as little as possible, still saving lives, but giving the possibility for more patients. Learn from external audits, yes, and that obviously always happens after these incidents, but you need to make sure that you collect your own data, that you are self-critical. We ended up being more critical than the external audits were, because we knew where coincidence and luck had been the case, and how do we actually introduce that into our planning. And then that has to be published so that others can assess their own systems towards what has already happened at other places. So this is also something I want to recommend is when the preparedness groups, clinicians in the hospitals, sit down with other experiences when they happen. For example, after the Paris attacks, we sat down once the numbers were published. We sat down with the group and said, okay, if this happened today in our setting, how would we handle it? What would happen? How would our plan be? And how would, if we actually exceeded our surge capacity, how would we organize this in our situation? Same thing with the Nice incidents, same thing with the Brussels airport, you have Las Vegas, you have all the others that have been mentioned. Every time there's a new happening in the world, sit down, and it's actually painful. It's painful to go through what happens if I have to start to activate plan B, what happens if we actually exceed surge capacity, how do we solve it? That's the only way you can improve your planning and improve also the clinical awareness. Back to the situation, this was already mentioned by Paul for the pre-hospital situation. Back to again mentioning that same triage as every day. So whatever you do every day will work on a day like that if you have planned it correctly. And then you have to improvise, like where do you actually make where do you localize your triage stations pre-hospitally? How do you avoid that non-severe injuries or walking wounded end up in the trauma center? Since the trauma center was 5 minutes away from the scene, how do you actually make sure that everyday system works? This, I'm sorry, it's in Norwegian. It just shows that the involvement of clinical leaders is important for when you're setting up the system of who is going who's the one who has the mandate to activate or push the red button, basically. Who is the one to decide what the disaster preparedness group, how that is combined, what people are included in that, how are they activated, how do we call in people, what personnel is actually being called in if someone pushed the red button, and so on and so forth. So that has to be with the involvement of clinical leaders. And then competence is much more important than your interior design. I learned that from experience in South Africa. This is the emergency department in one of the major hospitals in Johannesburg. And their competence and their way of triaging and managing many patients is far beyond what we can ever do in Norway because of different patient range and experience, or volumes, basically. So back to, again, the training. How do we train? And again, if you look at the individual skills, that's like ATLS, DSTC, other courses that can give the individual members of the teams their ability to do their everyday job, also in a situation when more patients. You need more people with those skills. And the same thing, you can train, you can do drills with your logistics. You can do drills, you can do tabletop exercises to include management and to check that your system is okay. This is from our latest full-scale exercise, and I don't believe much in full-scale exercises. They take away your preparedness that day. It costs a lot of money, but sometimes it's probably there's a reason to do it, and that is very often to detect the gaps between the different parts of the healthcare system. This was to test the pre-hospital ability to evacuate from this chemical huge catastrophe, and we took that all the way into the hospital in order to see the transfer between the different parts of the system. Now inside we do triage in the emergency department, just as a small, still paper patients, but we have changed, based on our experience, we have changed our triaging to being only one clinician, to be a multidisciplinary team of one surgeon who's the head of the triage team, one internal medicine specialist, and one anesthesia specialist, based on the experience we have from these drills. And we have made lots of adjustments by these drills, and it's actually not to train the team we are training during the triage, it's actually to see whether our system works or not. And we have, the reason why we changed this is because knowing that multitasking doesn't work for anyone, and knowing that it's too much for one person to have the full responsibility for all the aspects of what happens in the emergency department, if you can afford it. We found that having a triage team that is multidisciplinary is more efficient. The other part is how do we train our surgeons who would be the leaders of the triaging teams? Yeah, we sit down around the table and we have cards with patients, and we just say, okay, you're on call tonight. Here are your first 5 patients coming in. After a few minutes, after you've been notified of some incident. There are simple ways of actually training this. The other part is how do we actually triage it at the door, and I think Avi also mentioned that the re-triaging, reassessing, and that is this accordion way of following the patients and knowing that the patients might deteriorate. But the initial triage has to be simple. Initial triage is patient is hemodynamically unstable or compromised, needs a team, and will go to the trauma bay with the team. If the patient is obviously severely injured but still physiologically okay, if you can't afford it, you can wait. That patient will need less assessment, but knowing that he can deteriorate, and so on. So what we did, and again, this is our alarming form in our emergency department for everyday trauma. To the left, physiology. In the middle, the orange is severe injury, and the rest are the green ones with no physiology, not obvious severe injury. And that is how we normally activate our teams. Well, if we use this and then we make our disaster plan on top of that, we use exactly the same. Instead of then giving teams to the reds and the yellows, now we give teams only to the reds because we're afraid of bottlenecks. But then we have to make, this is from our emergency department, we have our 6 bays or 6 beds for severely injured. Those are the red beds. And then we have a big room for the yellows with teams so that we can assess when they are deteriorating and can upgrade them. And then we have the greens. So this has been developed over the time because we have done these small drills. And Paul was mentioning the supervision of trauma teams, the fact that the surgeon at the door cannot assess how the teams are doing in the trauma bays, in the operating rooms, in the ICUs. And then you need to have those leadership surgeons, like Avi was mentioning as well, in different stations around in the hospital, so that you can actually assess that things are happening in the right way. And that's what we call, and has been described obviously by experts long before us, as a dual surgical command. This is also assessing, it doesn't stop at the emergency department. So how it works at the different stations inside the hospital has to be also tested out with drills, tested out who is going to man those stations, and how do we make sure that there are no bottlenecks, and that we have an efficient follow-up of the patients. Same thing even before you enter the hospital. If there is a danger of chemical injuries that has to be decontaminated. We're in a cold country here. And how do we do that? And how are the pre-hospital, pre-triage team trained in order for this to work? Because it's very seldom that this happens. So we need to drill it often so that we know that the day it happens, we will be able to do. Surge capacity, not limited by rooms or number of personnel. I think that is the general experience from lots of these real-time mass casualty incidents. And I want to again back to the same issue of British Journal of Anesthesia, the global survey trying to point at the main worries of experts who have been dealing with real-time mass casualty incidents. They're pointing again at the organization of the human resources, the competency of human resources, but also the follow-up of clinicians in the follow-up of the treatment of these patients. So individual skills, yes, and make sure that you build it so that every clinician can have a similar role as they have every day. You don't suddenly become a trauma surgeon just because you are one of the people responding to a mass casualty incident. So almost to the end then, the devil is in the details that has been mentioned, making sure that that you have a good systems for communication. We have radios in our triaging team, and we decided that we can only have one radio because 2 radios is going to make noise. So you need to have one person with one radio having communication with other parts of the teams and so on. It has to be tested out for functionality. Cell phones are not going to work. Food has been mentioned. Supplies, important to have a plan for that, but that doesn't seem to be the biggest problems in most places because that can be planned beforehand. But also the planning ahead for the next weeks has been mentioned, and also the psychosocial follow-up. I think it's important. Documentation was mentioned. What we decided was to have numbers on the patients in addition to their own names for 3 days before we let go of the paper and number 1, 2, 3, 4, 5. There are different ways of doing this, but it has to be mentioned that it's a vulnerability. And then media strategy was mentioned. And again, I think that has to be on the clinical side. It's not management who's going to communicate with media. It's those who are responsible for the clinical management, because that is the only way to satisfy or to give limitations to media, because we're living in different worlds, media and healthcare workers. Summing up, this is multidisciplinary effort. It's not an I, and clinicians have to be involved in the planning. It has to be based on existing system. We need to train individual competence, drills, frequent drills to adjust. And then we need to have the clinical leadership to improvise on top. It has to be the most experienced leaders have to be the ones running the situation when it happens. And then full-scale exercises, maybe, but not too often, I think, but to identify necessary gaps, and then having a media strategy. Thank you.